Good afternoon, everyone. Today, we are very fortunate to have Dr. Nonhlanhla Mbenenge with us. She's a virologist who's going to educate us on HIV, or the human immunodeficiency virus. She's going to share what she knows with us. It's important for us to understand the virus in order to support people, for people to be adherent to medication. And she will share with us how the virus works, how people are diagnosed with HIV, the importance of taking treatment, how the treatment works, and then also she is going to cover drug resistance. And I'm sure these are terms that we are all familiar with, but we probably don't understand the detail of it. And so, Dr. Mbenenge, I just want to thank you for being willing to share your knowledge with us. And before you start, can I just open for us with a word of prayer? Father God, thank you so much that as a church, we have access to people who are really informed on various topics. And for today, I want to thank you for Dr. Nonhlanhla's willingness to share with us her knowledge on HIV. Lord, as a church, we would like to support people. We would like to do away with and address stigma and discrimination in our church so that we can support people, dear Father. We also want to educate people who are walking this journey so that they don't have to walk it alone, but we can better understand what people are going through that are affected and infected. So be with us now. Thank you that we can learn about it, and please be with Dr. Nonhlanhla. This is my prayer in loving name. Amen.
Amen. Amen.
Thank you so much. Over to you.
Good day to everybody. Thank you, Connie, for the invitation and for the introduction. Okay. I need to make a disclaimer as I am employed that what I'm going to talk about is at my capacity, not as an employee. And though I teach and I work at the Vets Medical School under the Department of Virology as a consultant there. Okay. So basically today, I just want to share my screen. So today we'll be discussing the basic facts about HIV. I'm calling it the basic facts because I will not go into the in-depth, otherwise we will take the whole day. In fact, they will not be enough in terms of discussing HIV. But we're going to highlight the key areas that Connie has highlighted in terms of if we understand how the virus replicates, how we diagnose, then we will be able to understand its management and how it's important in terms of taking the ARVs. It becomes very important such that if one becomes non-compliant, there are complications, serious complications as a result of it. So basically, I'm going to go through this outline just to take you briefly where we come from, our history of HIV as a country. I'm not going to be focusing in terms of global, though I'll show basically where we sit in terms of global prevalence. The burden of HIV disease, I'm going to highlight in terms of the terminologies, as Connie has said. Sometimes we take for granted that we know what HIV means, but the terminology, once you're so used to acronyms, it becomes lost in terms of what does it mean. We're going to be looking in terms of the infection of HIV infection. That means involves how the virus enters our body, how the virus replicates, so that we're able to understand, because that impacts in terms of HIV testing and impacts on HIV treatment. And that's when we're going to be concluding. Now and then I'm just going to reflect on my notes so that way I know where I am and so that I cannot tally in terms of time, because if I'm passionate about the subject, then I might find myself dragging in terms of time with the subject. When we start, we're going to look in terms of the history, in terms of HIV. Where do we come from in terms of the HIV epidemic? If we look back, it was in the 80s when cases were seen with people presenting with funny disease. Their immune system was destroyed and the body was not able to protect itself from opportunistic disease. And I remember I was still young in those times, but if you look in terms of history, people look at that time like, no, it's just another disease. It could be combated very soon. That was the thought. And by the time it was 90s, we were seeing the prevalence was getting higher. And if this is history in terms of coming to our countries, in our country at that time, the early 90s, was still around about less than 1%. And people were looking in terms of probably one of those American conspiracies in terms of infection. And then by the time it was going to the mid 90s, late 90s, we saw a scourge of the disease. It became just in like a few years' time, like 60% in the hospital were full with cases of HIV. In fact, it was AIDS at that time. People were, you could literally see the signs that this person is really sick. And then we went through what we have termed now Mbenge's denialist in terms of HIV, that period, and there was late 1990s, there was treatment action campaigns and people advocating for ARVs because at that time ARVs were seen to be working and they were available in other countries. And from that period of time, looking back from 2004 when we had the ARVs, we have been trying to combat the disease. And looking from that history, we had already majority of cases, already South Africa was in a crisis at that stage. So now we are at the time where we are trying to now to control the disease. And we know if you look in terms of now the burden of disease from that time, what the scourge has led us to is looking at in terms of the prevalence. And if you look in terms of this graph, you can literally see that Africa was in crisis. And not just Africa is in crisis, South Africa is in crisis. Okay, it's not a lost crisis, okay. Though our prevalence is very high, and if you look in terms of this table, you can literally see that, I'm not sure whether my arrow, okay, yeah, it works. You can literally see the group that is highly affected in terms of HIV, 15 to 49-year-olds. And this is our youth, and this is our working class. And these are the people that with the highest prevalence, if we look in terms of that. And as a country, we're sitting with, this is a report for 2018 from the Human Science Research Council, where it put us to at 7.9 million people who are living with HIV in South Africa. This was 2017, 2018 report. And as in terms of the age group and which the highest prevalence, we're sitting in terms of the HIV prevalence at 20.6%. That's very high. Okay. So South Africa, if you look in terms of global, HIV is an epidemic in our country. So we need to come to a stage where we are able to control the disease. Okay. This is still just a reflection of where we are. Still talks about the same prevalence if you look in terms of age and sex. And you know that you can see from this graph that female, we carry the bigger burden than males. Okay. And this can be explained in terms of epidemiology. Women are more in terms of numbers than men, and we more susceptible than men in terms of the disease. But if you look at the age, this is the working class that is highly affected. And if you look in terms by province, you can literally see that we're sitting with the highest province with KZN, having the highest prevalence in terms of provinces of HIV. I highlighted here Gauteng, and if you look in terms of the numbers there, you can actually see that Gauteng, if you look, it's sitting around about number 5 or 6 in terms of its prevalence. But I would not be sitting and comfortable and say we're sitting there because Gauteng is the area where it's industrial area where the numbers might be not reflecting it might not be the true reflection of the status in terms of prevalence, since people are coming in and out of the city, and they might be missed. We come to Gauteng in terms of work, and we've got our own homes in other places. So this number might not be a true reflection, but still 17.6 is very high. So I want to, before I start in terms of the actual presentation, determine where we are. We, with HIV, knowing that we are the high epidemic country globally in terms of HIV, we've moved where gone are the days where we started worrying about giving ART with a CD4 of less than 200. We have to wait for the period of AIDS before we can start treatment. We shifted, if people can remember, then we moved our target to 350 in terms of starting treatment. Then we moved from 350 went to 500. But currently we are at the stage in terms of our strategy to treat all, diagnose and treat. So all those that are willing to start, and I would advocate for that. The sooner we start in terms of ART, that's the best to give people a lifetime of healthy living. Okay, so we are this strategic from 2016, the 1990 strategy. These are the 3 pillars of HIV that we are looking in terms of. We want at least 90% of our population to know their HIV status. That means people must go and test. Okay. So for all those who have tested positive, we want them to be starting on ART. Okay, and once you start on ART, it needs to be consistent and sustained. Okay, so all those 90% of people who have tested positive needs to be on ART and be sustained. We should not be having lost to follow-ups in terms of management. And 90% of those who are in ART must be suppressed. And research, because we are scientific people, we have proven that if people take their ARTs and they are suppressed, the transmission rate of the virus is low. Okay. To curb the disease, we need to have that population, all those that are infected, to be suppressed, not to be able to transmit the disease. And if we keep to this strategy, we will win this war, because we want to see the next generation being free of HIV. Okay. So let's start with the talk. And as we started the talk, I wanted us to basically look in terms of terminology. And this is where I like to have people next to me, not to talk by myself, and to ask, what do you understand in terms of HIV? I always get good answers when it comes to people. When I ask this question, what is HIV? What does the HIV stands for? Okay, and the majority of us, we do know that it's a human immunodeficiency virus. H meaning for human, I means for immunodeficiency, and V for virus. Okay, H being human because we humans are the carriers. So, and then immunodeficiency because it weakens the system or destroys our immune cells. And thirdly, it's a virus. And if you see, virologists, we are not difficult people. We are straightforward people. We don't complicate things. We call it as it is. It's what it does. It destroys our immune system as individuals. And it's a virus. So one will ask, is that what then is a virus? Okay. The term comes from the Latin word. I will not bore you about it, but it simply means poison. Okay. So in the olden days, they could see literally that this gem literally is a poisonous. They didn't understand at that time. So, but then they could relate with it's very poisonous. Okay, from the venom portion of it. So we've come to realize that it is one of the microorganisms, very small. We will not be able to see with our naked eyes, but we will see how it affects us. Okay, so it needs to be in a living cell. It needs to be in a living body for it to be able to replicate and show and cause disease. Okay, and the structure next to it, we will come back to it and just look at it. It's very interesting because that's where we're going to be focusing in a few slides that are coming up. So the other thing in terms of terminology is when people confuses HIV with AIDS. So it becomes, does HIV means the same thing as AIDS? That's the question. But before we answer that question, let's understand what its AIDS stands for, because it's an acronym as well. So it's an acquired immune deficiency syndrome. Okay. I told you, virologists are not complicated people. We call things as we see it. Okay. So that means we have to acquire, and it must affect your immune system, depreciate your immune system, and must cause a constellation of symptoms or constellation of disease. So there must be cluster of disease. So is HIV the same as AIDS? So if literally from looking at that explanation, you can literally tell now that HIV is not the same as AIDS. HIV is a virus, and HIV causes AIDS. Okay. So, and AIDS, it's not just it causes AIDS, it's a late stage of HIV replication in one's body. So it means it takes time for the person to reach an age stage. You will not see immediately. That means the virus needs to literally destroy the immune cells to the stage that where the body cannot protect itself, and the person is able is infected with opportunistic infection. Okay, I hope that is very clear. So the other thing that we need to able to explain clear before we get in terms of the infection is the immune cells. Okay, because we're going to be talking about the CD4 counts. What does CD4 counts? And then we can virus affect the CD4 cells. So virus affect the CD4 cells. What are these CD4 cells? Basically, the simplest is these are your immune cells. I will always call them as your police or your soldiers. In fact, it becomes not even just police, becomes the target, your protective cells, your big guns in terms of your immune system, so your CD4 cells. The CD4 cells are just, if you look in terms of the blood analysis, are white blood cells. We call them medically T lymphocytes. Okay, so what they function for, they are able to kill abnormal cells. If they go around and investigate around your body and they see that this cell is infected, they chew up the cell, they literally destroy the cell. And they're able to link up for your immune system to produce what you call antibodies. These are other arm of your body is able to fight the infection. Okay. So looking at antibodies, it's a protein secreted by the other arm of your lymphocyte. We call them B cells. So the B cells secrete these proteins. Basically, they're able to neutralize the virus. They will hold the virus, able to neutralize it so that it doesn't go and infect other cells, while the whole immune cascade comes and to remove the virus. Okay, so they take the cells, these antibodies, they go and take all these cells that are got infected so that your CD4 comes and clean them up. Okay, so this arm of the immune system doesn't function separately, they fight together. So we've got a very powerful way of clearing up infection in our bodies. So if we've got such a powerful immune system, one will ask, why are we not clearing the virus? We'll come to that. Okay, so let's look in terms of now the HIV infection. What happens? It's a beautiful picture I've put there. If you in terms of analysis of the virus, this bottom portion that is fully orange, that's a cell, and they were able to, using technology, able to visualize these are HIV viruses that are coming out of the cell. That's how beautiful this picture is. So let's come and look now before we tackle the virus and how it infects us. Start with the structure, because it becomes the key. The structure becomes the key. Look in terms of, on the picture on the left, this is the actual structure of the virus. It's got these surface proteins, sort of like arms. We can call them arms. And it's got an envelope. Inside the envelope, it's got key protein enzymes and the genetic material. This becomes the key. To explain why I'm saying it's the key. Let's start with the arm, because it becomes important. The arm's got two proteins. It doesn't matter at this stage, the names. You just know that on the surface, there's this protein. And this protein is, so I'm saying it's like an arm, because it's the one that is going to utilize to be able to attach itself to a CD4 cell. If you look at the picture on our right, and you can see on the orange portion, this is a cell, a CD4 cell, and the virus is going to utilize these surface protein to be able to attach itself. And once it attaches itself into the cell, it's going to allow the virus and the cell to come together, to fuse. And once it fuses, that's what the virus wants. Once it fuses, it's able to lick and open the cell wall, cell membrane of the cell, so it's able to inject itself the core material. Okay. When I'm talking about the core material, I'm talking about these components, which are very important in terms of the viral replication. I'm not going to bore with you, but I need to highlight there are four of these, because it plays a significant role in terms of the virus replicating and in terms of how we manage the virus in terms of the ARVs, because I'm going to talk in terms of that. Is three enzymes. We've got the integrase, we've got the protease, we've got the reverse transcriptase. These are enzymes the virus needs in terms of its replication. And it needs its genetic material. Okay, genetic material is an RNA. Our genetic material in our bodies is DNA. So we are DNA, the virus is RNA. Okay. So what the virus needs is the first enzyme, the reverse transcriptase. Okay, look at the reverse transcriptase. It needs it in terms of when it replicates, it needs to change itself to become a DNA, because we are DNA. So if it comes to our body, it needs to be a DNA. So it changes with using this enzyme to a DNA. That's where one of the ARVs targets. The ART treatment blocks that enzyme so that the virus cannot change itself to become a DNA. So you are able to block the virus, because if the virus doesn't change, it becomes easy to clear it from the system. Okay. The second one is the integrase enzyme. So this enzyme the virus needs, let me go to the next picture. Okay, if you look in terms of this picture, so the virus, once it enters the cell, here, point number 3, it's going to change itself to become a DNA. Okay, so once it changes itself, becomes a DNA, it's going to go to our nucleus, our engine now, and go incorporate itself in our DNA. So now that's a problem, because now the virus, once we allow the virus to incorporate itself in the nucleus, it becomes part of us. Okay, because now the cell engine, it's got a virus in it. If you look at that on this cell, the CD4 cell, that red component, which is a virus now. So now the virus takes over the cell and start making itself copies. Okay, it starts replicating itself, making itself. And in one cell, we can have millions and millions of copies of the virus. Okay, and then it's going to go out. One of the ART that we have, drugs that we have, it blocks this stage. So we are able with the ART to block the virus from not going inside the cell, so not incorporating itself into the cell. So once the virus has replicated itself, it's going to go out. The cleverness of the virus, it doesn't destroy the cell because it still needs a cell to replicate, to make itself. So other of its copies are going to leave the cell and leaving it intact, and they're going to get matured using the third enzyme, which is a protease enzyme. An enzyme. So one of our ART blocks this this enzyme too. So if you look in terms of, if you understand here, we understand why HIV becomes is a chronic disease, because now it goes and incorporates itself, and once it becomes our DNA, we cannot remove it from the system. Otherwise, we have to destroy ourselves. Okay. So that's why this structure becomes very important in terms of understanding the HIV infection, and it's important in terms of understanding how the ART works. Okay, because each of the ART blocks the stage of the virus so that it cannot replicate. Okay, I hope that's clear, because now I'm going to move faster. Okay. So in terms of transmission, we know the commonest method which gives the virus the stigma is in terms of unprotected sex. Okay. Virus can be transmitted through the vaginal secretion, can be transmitted through the anal. As long as bodily fluid, the virus is able to be transmitted. I'm saying it gave it a bad name in terms of stigma, because now people think that when you're infected, it's basically promiscuous. Okay, but it's not necessarily the case. Okay, other means as well of being infected in terms of mother to child transmitted. If I'm a pregnant woman, I can transmit the virus to my baby, and mothers can be through the childbirth and can be through breastfeeding. That's why I'm saying the virus is found in bodily fluids. Even those drug users as well, they're able to get virus if you're using a needle from somebody who's infected. So there are various means in terms of being exposure to bodily fluids. Okay. So if you understand that the virus is transmitted to bodily fluids, then you understand in terms of how to protect ourselves. It becomes important that way. I needed to highlight this piece. You cannot get the virus from the saliva. People worry that especially we women who like kissing, then COVID, we like doing less kissing nowadays, and because we're doing less touching because of the COVID, but the virus cannot be transmitted through saliva, tears, sweat, and urine, please. And you cannot transmit the virus in terms of sharing of plates, sharing of spoons and cups, sitting on the toilet seat. I know people have passed by that, but still, one thing I've realized, people think mentally that they have accepted HIV until they meet somebody and somebody tells them their status, and the fear starts again. Okay, and then people feel like, oh, they will not want to show it directly, but you can literally tell when somebody comes and say, I'm HIV positive, people's countenance change, their face changes a lot, changes, and you wonder, I thought you said you understood in terms of HIV. But, so you cannot get HIV from the air, you cannot get HIV from mosquitoes, please. So I'm gonna to run through that. I know it's been said many times. I can. So how do we diagnose HIV? Simple. We've got screening tests where we screen for antibodies. And there are other ways still can be used in terms of screening, but we don't utilize them as screening. We utilize them in terms of monitoring. Okay, CD4 cell. We know somebody who's got low CD4 cells. There's a potential of an immune deficiency disease, and HIV becomes one of those immune deficiency disease. Okay, but we don't use CD4 to diagnose. We use it in terms of monitoring because we want to see a high CD4 cells. That means your immune system working very well. we've got what is called viral load, where we count the copies of the virus in terms of the blood. So we know that once you've got a copy of the virus in your blood, that means you're infected, simple as that. And the higher the viral load, we know that it affects your CD4 counts, because if your viral load becomes high, your CD4 is going to drop, because basically the virus is destroying your immune cells. We've got what we call the P24. I forgot to explain it in terms of the structure, but this is a protein of the virus. Okay, it's secreted by the virus itself. So our test incorporates that as well, but we do not utilize the P24 because it's one of those that markers that comes early and can disappear. Okay, but these in terms of HIV tests that we're utilizing. So before I go into details in terms of that, I just wanted to show the timeline. It helps in terms of understanding how we diagnose HIV. When you get exposed to HIV, that means you get exposed, becomes infected at day 0. It takes a while. The virus will be in your body, but our test will not be able to pick it up. Okay. So if you look in terms of our tests that we have, the only time you're able to pick it up is with the test that I said, a monitoring test. And about the second, after the first week to going to the second week, that's where we'll be able to detect in terms of is there a virus or not. But we are not utilizing those tests because they're expensive. Okay. So by the from the second week going up onwards, your body amounts what you call antibodies. Okay. Remember when I was explaining the antibodies, I said these are secreted by your cells from the exposure. Okay. They're able to detect what's going on around the cell and able to mark the cell that, hey, something is wrong with this cell. Okay, so those are antibodies. They're mounted by your body after being exposed to an infection once they see the infection. Okay, so it only happens 2 weeks down the line, and it differs with people. Okay, so our antibody test, that's what we utilize in the lab. If you look at number 4, only skin able to utilize and detect the virus around about the 3rd week of the infection, 3rd to the 4th week of infection. So it takes me to this structure. Okay, so from exposure, we're going to, the person will only have amount immune response, the antibody response, around about the 2nd, 3rd week of the infection. Okay, so and we're going to be able to detect around about the 4th week. And what in between here, so what you call a window period. Okay, because the antibody test will reflect this, will not be able to pick up the virus. So what does I mean in terms of that is what I've just highlighted, is that from the exposure to the test being positive, antibody test positive, even the RNA, if you get infected today, you don't immediately going to test positive. Okay, so that's what you call the window period. That means our test is not able to pick up the infection. So people will test, like get exposed and they go and test and they're negative and they're going to say, hey, I'm negative. And they think that now they've got what we call carriers who are HIV negative. There is no such a thing as a carrier who's HIV negative. Okay, once you become infected, you are infected with HIV at this stage. We cannot clear the virus, cannot cure the virus. So it's just that there's the point where our test cannot be able to pick it up in terms of that. So I hope that is clear. It just stays the same thing. Around about the 3rd week, our antibodies will be able to pick up the HIV in about 80 to 95%. And remember, when you get your HIV results, we always say wait and repeat after 3 months. Okay, that means in that time, you are not participating in any risky behavior that exposes you to the virus. And after 3 months, we know 99% of people would have mounted a response in terms of the infection. Okay, so you get comfortable with the results after 3 months, should you have not exposed yourself to any risky behavior in terms of exposure to the virus. So in terms of diagnostic, that is what my work is all about. We've got what we per guidelines, we've got 2 tests that we do. We do a screening test, we do a confirmatory test. Okay. And that's when we're testing. And should we do a screening test and it says negative, we always say we're going to release those results as negative. Okay. Remember the window period. So a negative result must not make you too excited. It just tells you be careful and repeat. Okay. In terms of 3 months. So if it comes out is positive, we do not release immediately. We do another test in terms of diagnosis to make sure that are we seeing authentic results. So what I'm trying to say in short, that when you see an HIV result, it's been checked and checked again to make sure that we do not release false results. So in terms of diagnosis, if you go to a clinic, they're going to do what we do called a rapid point of care test. It's a rapid test. That means you can do it from fingerprint. And if it's negative, they're going to tell you negative, and they're going to advise you to come back and repeat the test in terms of 3 months of what I've just said. Okay. Then we do have the home-based test at this stage. That it works the same way. Okay. Should the results be positive, because that's a screening test, that's test 1. You need a confirmatory test. That's where now you need to go, if you're doing it at home, you need to go and test tell a doctor they're going to draw blood. And once they draw blood, they bring it to the lab. And in the lab, we've got different machines that we test with. We don't test with 1 machine, we test with 2 machines to verify the results, and the different manufacturers in terms of picking up the disease. Okay. And that's what's going to tell you in terms of are you infected or not infected, okay, with HIV. So once you're diagnosed in terms of HIV, so now you know your status, you're definitely HIV positive. The doctor's going to do a viral load in terms of measuring the copies of the virus from the exposure. And one thing I wanted to highlight here is that a higher viral load, that means the virus is not controlled. Virus needs to be controlled. The higher the viral load, the higher the speed that you're driving it towards having AIDS. And okay, that's where the ARTs becomes very important. Okay, because that's where we want to control the disease. Okay, we want to see not just a low viral load. We want to see an undetectable viral load. Undetectable viral load doesn't mean you don't have the virus. It means the virus is very low in the blood, okay, such that the copies that are there are not enough for the system to be able to detect. We cannot clear the virus. We cannot cure the virus. We cannot highlight that enough. People see a result and it becomes because we report it as undetectable. In terms of the copy number, and people think that I don't have the virus. No, it's not that the case. Okay. So as I've highlighted, CD4 count was one of the monitoring tool. Once you diagnose with HIV, the doctor will do the CD4 count, and you want to high CD4 above 500 international units, because the higher the CD4 count, the good the immune system is. Okay, the lower the CD4 count, the bad state of your immune protection in terms of infection. So this is what happens. If your virus goes up, your CD4 comes down. If the virus comes down, your CD4 goes up. So they always work in that synchrony, the two. So how do we treat? That's where Connie was talking to me and said we need to highlight this. It becomes very important in terms of people understanding in terms of how the ARVs work. Okay, and I just tell you, HIV is a chronic disease. People don't mind to talk about, hey, my high blood pressure, my BP, it was like 250 over what. Oh, my sugar, in terms of your diabetes, which is a chronic disease, they're able to talk about that. Oh, my sugar is not out of control. It's the same thing with HIV. And I pray that we'll reach a stage where we become so accepting of people with HIV and do not stigmatize. It's just a chronic disease. It's better than, I always say, if diabetes can be cured, and most time it's one of the lifestyle disease that if managed properly by the person, it can be cleared. But this becomes a chronic disease, and we should be more empathic to a person who's infected than to stigmatize them, because now it's, once they have it, they cannot do anything about it. Okay. And the treatment is lifetime. We complain in terms of taking antibiotics for 5 days, and this is a lifetime taking of ART. Though we've come a long way in terms of the treatment, is less burden in terms of pill load, but it's a lifetime of taking the medication. The things that the UN AIDS information will highlight, and it's repeating itself: HIV, medicine can't cure HIV. HIV cannot be cured. People with HIV take a combination of the treatment, which I'm just going to show you right now. And HIV medicine reduces the risk. That means ART reduces the risk of transmission. We've already highlighted. I'm just repeating it just as in terms of emphasis of what in terms of the disease. Important slides now for those that are already diagnosed with HIV. How ARVs work. And if you remember, when I was highlighting in terms of replication, that each of the medication that we are giving out, the ART, works against the virus. Okay, it doesn't work against us, it works against the virus. From the point of when it enters the cell, we're able to block the virus, not to change itself, mutate itself to become a DNA virus, to blocking it in terms of it does not integrate itself in terms of become part of us. Should we fail there, we're blocking the virus not to mature. Okay, that's how ARVs work. They block the virus. Once you block one of the stages of the virus cannot replicate itself. Okay, that's what we want. We don't want the virus to replicate itself. Once you get infected, we're locking the virus. You put it, so I can use an analogy in terms of we're putting the virus into a cell, lock it into the cell, so it cannot go out of the cells. It cannot form many copies of itself. Okay, that's how the HIV treatment works. Okay, and this is looking at history. When we started with ARTs used to be a burden. It felt like a plate full of pills. People would get massive of different pills to drink. And we've come to a stage where it's 1 pill a day. It becomes like an oral contraceptive, 1 pill a day. Okay. I know we tend to say on the medical side, say it's 1 pill a day, you know, it's not bad. And the person going through the stages might feel like that 1 pill a day is a burden. Okay. But that's the only way we can manage the disease. And that's the only way we can live a normal life. Okay. We need to live a normal life. We need to look at the brighter. There is at least something to, at this stage, we're able to control the disease and give life. Jesus has promised that he came to give us life and give us more abundantly. Okay. And this is, at this stage, what God has given us, 1 pill a day to be able to live a normal, healthy lifestyle. And we can live with a normal, healthy lifestyle with HIV. So let's continue in terms of treatment. This is important and stress enough. It needs to be taken daily. It's a daily medication and it's for life. Okay. We know that if you take a medication daily, it reduces in terms of the virus because it controls the virus. It's able to results. Once you reduce the virus, your CD4 cells, your immune cells, going to increase. You know, if your immune cells increase, your immune function in terms of your protection increases, and we live a healthy lifestyle. What do we want more? Isn't we want a healthy lifestyle? That's what the ARTs are providing for us. Challenge, and I've stressed, I don't know how I'm going to stress it some more in terms of non-compliance. Missing a pill, and people will give you a reason. I'm just highlighting here reasons what of our patients tells us they are tired. They're not feeling like it. some will tell you I'm not seeing benefits, because at this stage we're advocating for people who looks healthy. We're saying as soon as you're diagnosed, take the ARTs. Okay, because we don't want the CD4 to drop. We don't want the immune system to lower, because picking it up becomes difficult. So we advocate to taking the treatment early to navigate in terms of keeping in a proper functioning immune system. But people will tell, I don't see the benefit because I'm healthy. Okay, I don't understand in terms of the implications thereof, because once that CD4 drops, picking it up, it's harder. The other thing is in terms of secrecy. You know, if you cannot tell even your best friend in terms of your status, becomes hard, because how are you going to take that medication? Because people will see popping and say, why are you taking out the pill? You know? And then it becomes like, the next thing they don't want to take the pill because you're in front of people, and then becomes a non-compliant because you're going to miss in terms of taking the dose. Okay. So we found that in terms of secrecy, because of the stigma, people, it leads to people not taking their ART and becomes non-compliant. Another thing is side effects. One thing I need to highlight, the more the ARVs are coming and the more we are knowledgeable about it, we're seeing less and less side effects in terms of the ARTs. In the olden days, definitely, yes. But currently, with what we are sitting with, and we have got best treatment so far. So the side effects becomes less challenging. Of course, when you're starting something new, you're feeling nausea, probably have some diarrhea, but it goes away. And nutrition, and of course, when you're sick, you need to take good nutrition. And this is terms of support. That's where those of us who feel, always say, it's grace that we are protected, always believe that it's mercy. We should be very supportive of the people who are on ARTs and they in a state where they are not able to provide themselves with good nutrition. We can be supportive in terms of that, because if you are sick, you need good nutrition. Okay. Support, so that's what I've just highlighted. Sometimes the person just needs a shoulder to cry on, a shoulder to say, this thing, you know, that's all they need. They don't need you to say, hey, take your medication, or how do you get infected? No, they just need somebody who say, hey, how are you doing? How you keeping? You're looking good, you know. And this boosts people wants to be able to live a normal, healthy lifestyle. And for us who are healthy, I don't know what it means, because we all sick one way or another, to be supportive of those who've been diagnosed with HIV and understand what when they're feeling, say, I'm tired, of feeling that I'm not feeling well today, and give them a boost now and then. So if the person doesn't take the ARVs for those reasons I've just highlighted, whatever the reason they could have for themselves, or not being mentally fit, or have not accepted their status, whatever the reason, the problem with not being compliant with ARV is a drug resistance. And we are seeing an increased numbers of drug resistance. Okay, problem. If once you start on ARVs and you don't take them, the virus, remember, it's an RNA and it changes itself. So it is able to mutate itself and change itself such that it's able to be defiant in terms of the current treatment the person is taking. Okay, so it's used to the drugs that they're taking, so it finds another way to escape those medication. And once it escapes, you're going to person present with increasing viral load, declining in CD4 count, opportunistic infection, and the person will be like, I'm taking ARVs, but they're not working. They're not working because now you've allowed the virus to mutate. And that means the drugs you'll be taking will no longer be working. Okay. And that means if you're no longer, the drugs are not working, we need to change our regimen. And we don't have much at this stage in the country to play around. And when we move you from one pill a day, we need now to individualize the pills. We go into the pill burden, where we need to give you other drugs that are going to supplement in terms of blocking the virus. The pill load becomes high, It's a cause now, because now we need to manage new diseases that will be coming up. Becomes challenging for even for the system, because now we need to incur many of these in terms of now navigating around how to manage your disease, in terms of further management, in terms of now the drug resistance. Okay. And doing the drug resistant testing is very expensive. So this diagrams are just highlighting what I've just said. Okay, in terms of number one is the virus was multiplying, the person takes their ARVs compliantly, the viral load reduces. But if people miss their ART, now the virus mutates, and now you've got new viruses that the drugs cannot work. That is what drug resistance we're worried about. And these mutated viruses are able to be transmitted, such that if a person gets infected with the mutated virus, even if they start ART, it will not work. Okay. And then we are complicating the picture now in terms of how to manage these cases. And this is a worrisome situation that we don't want to face as a country. And I've just said HIV is an epidemic in the country. We've got a burden of TB. Now we've got a burden of corona. It becomes taxing in terms of management. Okay. So this is what we're trying to navigate around, and in terms of managing, properly managing, and as encouraging people to be compliant with their treatment. Okay. So in conclusion, a person can live a better lifestyle, a better life with HIV. It's not a death sentence anymore. It's 1 pill a day, which can be monitored. And in terms of, is your CD4 increasing? Is the virus being stopped from replicating? And a person can live a normal, healthy lifestyle. And you can stay healthy. And health is not the absence of disease. Health is a state of mental, physical, and spiritual well-being. If you've got those, you are healthy. Okay. Because if you understand in terms of the disease that you need to take your ARVs, and you've mentally accepted it, and you spiritually know that you are a son or a daughter of the Most High, and Jesus came to give you life and give it more abundantly, what more would one ask for except to live according to what the Lord has provided? So just in summary, we've got an epidemic of HIV in South Africa. If you look in terms of global prevalence, I'm asking all not to judge, please. If you look at that, we're bound to meet a case of HIV somewhere. So we are not supposed to judge. Okay. Being HIV positive doesn't mean you've got AIDS. And people can stop saying that I've got AIDS, and find somebody who's healthy that I've got AIDS. You don't have AIDS. You've got a virus. Okay, that's in your system. Different things, and it's just a chronic infection as it is with hypertension and diabetes. And we've talked in terms of the routes of transmission, which the commonest so far is in terms of sex. And we need to have the discussion. And it's my wish for the church to talk more about sex, especially with our youth. Okay. We need to advocate for our youth to live a healthy lifestyle in terms of waiting for abstinence in terms of their relationship, and is possible. And this is a discussion that we should be having more to encourage our young people that what God has advocated, it is achievable. You know, we are here to be different. We are ambassadors of Christ, and we can live differently than the world. As the world advocates sex, we can advocate abstinence, and it is possible. And the role player, we need to be part of the role player in terms of controlling the disease. We want a new generation that is free of HIV, and we can have it if we maintain to the 1990 strategy, which globally has been accepted. 90% of our population, we need to know our status. Okay, we need at least every year, if not twice a year, once a year, go and test and know your HIV status. And once you have known your status and it's positive, it's not the end of the world. Just take the ARVs as soon as you can to maintain your healthy CD4 cell immune cell function, and remain with an undetectable, with a low viral load or undetectable viral load. Then the transmission will be less, and the next generation we will not see HIV. Thank you, Connie. That will be the end from my part.
Thank you so much, Dr. Mbenenge. That was so informative. I hope that a lot of people will benefit from it, because we would like to reach the stage as a church where we are able to form support groups for people who are affected and infected, because for many people, it gets too much to even just take a tablet every day. And so they get treatment fatigue. And it would be nice in a support group if we can just encourage people, just take your medication. I know of people who have other chronic illnesses, and the taking of treatment every day gets overwhelming. And it is the case even with young people who are born with HIV. They often tell me that, taking a tablet every day and medication every day just gets too much. So my prayer for us as members is that we will not judge people, as Dr. Mbenenge has said, that it's not our place to judge. It's not our place to discriminate people against people who are HIV positive. We have never walked in their shoes. And so let us be the kind of Christians that God wants us to be there for one another, to support one another, and where we can, in the very near future, have support groups for people that are suffering with HIV, so that they have a support system where they can openly chat with people in their churches, and where we put an end to this, where we discriminate against people for something that they often cannot even help for. So thank you so much, Dr. Mbenenge. Can you please close for us in prayer?
Will do. Thank you, Tiffany. Let's all close our eyes as we pray. Our kind and loving Father, we thank you, Father, for who you are, a gracious, a loving Father, long-suffering towards us sinners, O Lord. That, Father, even at this time, your mercy is upon all of us. Look upon us, O Lord, with favor, Lord. Be with those, Father, that infected with the HIV, and encourage them, Father, through your word, that you will not forsake them. You love them still, and you're carrying them, Father. So, Father, I pray for their healing in terms of mentally accepting the disease and spiritually walking with you and working according to thy word, with their promises that, Father, you have come, that you give us life and give us more abundantly. And Father, for us, some of us who not infected with the HIV, able to understand and not judge. As Father, as we look upon others, may we remember the dirt in our eyes, so that we do not point fingers, O Lord, and able to gossip. Cut the tongue of gossip in terms of people's status, Lord, and help us to be more understanding and more loving and more supportive towards this disease, Lord. Help us, Father, as we love and navigate with those who've got other diseases like hypertension, diabetes, Father, able to be supportive of this disease as well. And that, Father, we can form groups that are supportive in the church to talk more of this openly, Lord, as we see the nearing of time. So that, Father, do not be hindrance into your children in terms of accepting thy word. Thank you for being with us, and thank you for this lesson. Bless Connie and their health ministry team. Bless our conferences, Father, as they allow these talkings, Father, and these teachings in our church. Thank you. In Jesus' name we pray. Amen.